Good morning, sir, ma'am. I'm Dr. Geetu. I'll be presenting the first case for today. Um, Presenting the history of a 6-year, 4-month-old male child who's a first standard student, first child of non-consanguineous marriage. Around 2 years of age, parents noticed that there was slight bowing of legs, and patient was found to have vitamin D deficiency, for which they took treatment for about 1 year and then later stopped. 1 year later, they also felt, although his bowing had disappeared, they noticed that he was not gaining weight adequately and he was short in stature compared to other children. 1 year later, again, there was urinary frothing. Parents took resort of Ayurvedic medicine, which was taken for 6 to 7 months for the urinary frothing, but there was no improvement. And later, he was admitted outside for evaluation of short stature and albuminuria. Later, referred to Amrita for further management. Significant negative history. There's no history of any polyuria, polydipsia, hematuria, no bowing of legs. Although it was there previously, at presentation there was no bowing of legs, no widening of wrist fractures, diarrhea, vomiting, no headache, hearing difficulty, no recurrent infections, no abdominal pain, fatigue, cold intolerance, no alopecia, visual disturbance, no dentition delay. Antenatally, he is the first child of non-consanguineous marriage. Other than subclinical hypothyroidism in mother that was treated, it was uneventful. He was a term LSCS with a birth weight of 3.2, and history was uneventful with no ICU stay, no failure to thrive or salt wasting. Postnatally, there was mild delay in motor milestone initially, but currently child is well with no deficit. Family history wise, there's no significant family history with just diabetes in both paternal and maternal grandparents and hypothyroidism in maternal grandmother. Father's side, paternal grandmother is relatively short. He has a younger brother who's currently 3 years of age with normal height. No other family history of any short stature, renal failure, renal stones, urinary frothing, no any fractures, proximal myopathy, no cataract or intellectual disability in any members of the family. Examination wise, child was active and alert. Weight was 13 kg at minus 2.8 standard deviation score with a height of 94.5 centimeter, which was at minus 3.8 standard deviation score with height more affected than the weight. Mid-parental height was between 25th to 50th centile, head circumference of 47 centimeter, upper segment, lower segment ratio of 1, arm span of 96. BP was normal, pulse rate was 110, and respiratory rate was 20 per minute. Significant findings was he was having a slight dolichocephaly, short neck, small hands and feet, periorbital puffiness, everted umbilicus, and a 5 into 3 centimeter cafe au lait macule over the left leg posteriorly, and a large blue neve over the right back. There was also a tiny opening on the skin in the right coccyx. He was prepubertal, and other than everted umbilicus, there was no other significant findings on systemic examination. This is the child, the dolichocephaly, puffy eyes, short neck, distended abdomen. He came with a certain outside investigation. CBC was normal with no anemia, with a ESR of 35, RBS of 71, creatinine of 0.3, with a calcium and calcium of 9 and phosphorus of 5.2, normal albumin, but a raised alkaline phosphatase of 1125 with a OT, SG, OT 74 and PT 30. And sodium was 135 with a potassium of 3.3 and a bicarb of 19. Vitamin D was slightly low, and TFT was okay, and cortisol was fine. And outside urine routine investigation was showing a minimum pH of 5.5, and albuminuria was present in 2 occasions, 1 plus and 2 plus, with negative glucose urea. No 3 RBCs were present in the urine routine, no evidence of any UTI. 24-hour urine calcium creatinine ratio was 0.4, suggestive of hypercalciuria, and also urine microalbumin was positive. And outside investigation showed a growth hormone of 1.38 and IGF-1 of 24.9 with a born age of 3 years. Outside ultrasound was also showing left renal small calculi and internal echoes in bladder suggestive of UTI, and also umbilical hernia with fat as its content. ABG from outside was showing pH, minimum pH of 7.307 and repeat without any intervention pH of 7.42 and a bicarb minimum of 16.6 and 19.8. And also a fluorocortisone furosemide test was done, after which urinary pH had reduced to 5. Patient was referred to our institute, and we repeated all the routine investigation. With the patient was found to have a normal sugar, creatinine of 0.37, SGOT of 53 with PT of 18. Albumin was normal, 4.3. ALP was again rise, it was 628 with normal GGT. Lactate was normal, celiac screening was negative. Again, potassium repeat was again showing 3.3 with a normal calcium and a low phosphorus of 2.7. Vitamin D was 23.3 with 125 dihydroxy vitamin D elevated at 194. PTH was 41 with a normal magnesium, and again there was a hypercalciuria with urine calcium creatinine ratio of 0.43. Urinary potassium was 46 with a potassium creatinine ratio of 9 milliequivalent per gram. There was also urinary phosphate of 69.5. 24-hour urinary protein was found to be 1.36 gram nephritic range, with 24-hour urinary beta-2 microglobulin, which is supposed to be less than 300, was 63,670. And stone profile wise, 24-hour uric acid, 24-hour citrate, oxalate was within the normal limits. So this is the serial phosphate levels and potassium levels that was done. It was showing phosphate low to low normal phosphate levels, and this variable phosphate levels is without any intervention. Same with potassium, with the lowest potassium of 3.3 and varying between 3.8 and 3.5 without any intervention. TMP-GFR was 3.4 milligram per deciliter. Urine routine that was repeated again was showing albuminuria with no glucose urea and no RBCs, no evidence of hematuria or any urinary tract infection. Repeat ABG was showing a pH of 7.4 with bicarbonate of 18, normal lactate, and anion gap of 8. This is the X-ray of the child. Although there are not gross evidence of any metaphyseal windings playing, small stress lines can be seen. Other than that, X-ray was normal. And again, we repeated an ultrasound. Although the outside ultrasound was showing renal calculi, the repeat ultrasound did not show any evidence, but there was echogenic sediments in the urinary bladder. Most probably the stone would have passed out. The summary, patient, a case of short stature or failure to thrive with periorbital puffiness dolichocephaly, with persistent hypercalciuria with nephritic range proteinuria with predominant low molecular weight proteinuria in the form of increased beta-2 microglobulin, variable hypokalemia with hypophosphatemia, mild normal anion gap metabolic acidosis with no glycosuria, doubtful renal calculi, stress lines on X-ray, and creatinine of normal to borderline. And we already ruled out a distal RTA since the pH had come to less than 5.5 with the furosemide fluorocortisone test. So it's a.
Do you want to give it a pause? I think we might want some clarifications. Ma'am, do you need clarifications?
The child didn't have any cataract or hearing. Did you do a formal hearing test for the child?
Ma'am, the child underwent both in our institution as well as outside. The cataract was looked for and other changes. Nothing was found. I think you did not mention that.
Yeah, I have mentioned visual disturbance.
So, thank you, ma'am. I'm not too sure about hearing, ma'am. I don't think we checked for hearing. That was not a prominent thing. I think the diagnostic possibilities probably we didn't consider. Hearing was not tested.
Yeah, it's just that we now know because the child had beta-2 microglobulinuria and other things, but usually now we are sort of sticking to getting a hearing done right at the time when we are investigating for renal tubular acidosis. Sort of, we've got it into our workup that
yes, ma'am. Yes.
Good idea to have it here. Maybe I'm not so sure whether DENS will eventually have hearing difficulty, hearing abnormality. So in this case, it may not be so pertinent, but just as a routine workup, we have included in our workup of renal tubular acidosis. It does help.
Yes.
Yeah. That's why I asked. No other reason. Anyone else? Do you have any? So you'll explain, Gitu, that why he has short stature in spite of not having such florid rickets and all?
Yes, ma'am.
Okay, okay. So we'll wait for that discussion.
Yes. So, ma'am, I think Gitu made it too simple. So all these investigations were done over, we had these initial investigations, we had developed some differentials, and then the beta microglobulin was sent later, and the 125 was also sent later. So, so she kind of put everything together. So this didn't happen in one day. So
that I can understand. Yeah.
So I think I don't know. We do have slides on differentials. Okay, let's move forward.
Other less likely differential would be hypocalciuric hypophosphatemic rickets due to NIPA defect, but since hypokalemia is there, it is less likely. And other causes can be causes of proximal tubular dysfunction, which are less likely, like Lowe syndrome, cystinosis, galactosemia, hereditary fructose intolerance. But since the acidosis is very mild, so all these and presence of renal stones make these diagnoses very, very less likely. And there are no other mainly renal involvement, no other systemic involvement is also there. So these become very less likely. And later we did the clinical exome sequencing of the child, and the child was found to have a OCRL gene mutation positivity. This was present in the intron 4 hemizygous and X-linked recessive with uncertain significance classification. Going on to the discussion of dense disease. So dense disease, they are a heterogeneous group of X-linked disorders that has previously been reported as X-linked recessive nephrolithiasis, X-linked hypercalciuric hypophosphatemic rickets, idiopathic low molecular weight proteinuria with hypercalciuria, nephrocalcinosis. And usually it is associated with triad of symptoms like low molecular weight proteinuria, hypercalciuria, nephrocalcinosis, or nephrolithiasis. Although there's a triad, but there's also mild heterogeneity of this disease clinical presentation. Genetics, it is caused either by inactivating mutation in CLCN5, that is in XP11.2, which encodes for a chloride hydrogen exchange transporter, that is contributing to 60% of the cases of dense disease. The second is the OCRL1 gene, that is our interest of gene, which is located in the XQ25 region, and it encodes diphosphatidyl bisphosphate phosphatase. And this constitute to 15% of cases of dense disease, and unknown mutations are seen in 25%, and even 10% of patients can have this mutation de novo. And all these transporters and genes, they are involved in the endolysosomal pathway in the proximal tubular cells. So we have this megalin and cubulin that is there, which is needed for transcytosis of various low molecular weight proteins and other ions, as well as for endosome, early endosome formation, and further recycling of this clathrin and cubulin, which will further help in the transport of various proteins, electrolytes. Specifically going into CLCN5. So CLCN5 is a chloride hydrogen transporter, and this facilitates acidification and helps in maintaining the electroneutrality. And if there is dysfunction, as already told, the endosomal cycling get disrupted, and there is impaired cycling of megalin and cubulin. Hence, this low molecular weight proteins cannot be absorbed. And because of this disruption, there is a reduced internalization of this megalin, cubulin, and disruption of progression to endosome, and affecting the recycling. And going on to OCRL gene, while the CLCL5 was mainly in the kidney, OCRL gene is expressed ubiquitously, and mostly very kidney, CNS, and brain have higher expression of the same. And what is OCRL1? It is actually a phosphatase, and one of the 5 phosphatase in the eukaryotic cells, and that helps in formation of monophosphatidylphosphatase, phosphatase, and that is key in forming for clathering, uncoating, and function of the endocytic machinery. And this is also important for primary cilium functioning. And it is because of this that in this gene, another spectrum loss disease, there is involvement of eye, brain, CNS other than kidney. So going on to how this OCRL gene functions. So when there is a mutation, it causes dysfunction of the endolysosomal system and primary cilium. And how does this happen? So when there is no OCRL gene, there is increase in the clathrin coated vesicles, and they fail to lose this clathrin cord. And because of and the other thing is there is a formation of actin crumbs as actin comets. Later there is increased, this is a normal endosome. Here we can see this the phosphatidylinositol monophosphate that is predominant, which is required for recycling of the endosome as well as formation of late endosome and lysozyme. But here when OCRL is affected, we can see that the phosphatidylinositol diphosphate levels are high, and also there is actin polymers formation on the early endosome. So this actin polymerization, when it happens, there is impaired trafficking of receptors through the early endosome, and reduced recycling back into the plasma membrane. And also even retrograde pathway to Golgi complex and sorting of cargo is affected. And also this OCRL affects function of cilium because of this actin polymerization. So going on to clinical characteristics, the core feature of dense disease is low molecular weight proteinuria, and is found in almost all reported cases. And the low molecular weight protein is constituted by the alpha-1 beta-2 microglobulin, retinol binding protein, vitamin D binding protein, chlorophyll-like protein, and in some cases we even get episodic night blindness due to urinary loss of retinol binding protein. And then we have hypercalciuria, that is a second most common feature that is present in more than 80% of both dense 1 and dense 2. And the other characteristic is it is often described as intermittent, and this intermittent nature could result in its underestimation. And nephrocalcinosis and nephrolithiasis can also occur, and that was detected more frequently in dense 1 than in dense 2. And proximal tubular dysfunction, that is reported equally in cases of dense 1 and dense 2, and incomplete form of Fanconi is more common, that is 60% have incomplete form, and complete is less common, only 10% in both dense 1 and dense 2. And considering glycosuria, it is more frequent in dense 1 than dense 2, 22% versus 10%. And the mechanism is said to be reduced this clathrin and megalin. They are also needed for insulin transport to the cell. And when there is no insulin transport, there is reduced GLUT2 expression in the PCT and low insulin level, leading to glycosuria. Bone abnormalities, they occur both in dense type 1 and type 2, 19 and 13% respectively. And the mechanism is disruption of calcium and phosphorus balance, and the decreased megalin and tubulin observed in dense disease 1 and 2. And this megalin and tubulin have affinity for vitamin D binding protein, and because that is lost, there is insufficient vitamin D resorption in the PTC. And one other mechanism is it also, megalin and tubulin also have a role in reabsorption of PTH. So when they are affected, the PTH reabsorption is affected, and there is increased amount of PTH in the proximal tubules, which leads to increased 1-alpha hydroxylase activity, leading to increased 125 dihydroxy vitamin D, and also increase the expression of NAPI, leading to phosphaturia. So these are the postulated mechanism for this calcium phosphorus balance. And acidosis per se can usually cause hypercalciuria, but here, since the acidosis is very mild, so that is not constituted as a major reason. And failure to thrive, it is seen mostly in dense disease 2 than in dense disease 1. And it is a typical feature of patients with OCRL mutation that they have very short stature, even below 25th percentile. And going on to one study, the same thing. The most common feature is low molecular. This is a study, meta-analysis, including 772 dense 1 cases and 143 dense 2 cases. Low molecular weight proteinuria was found almost in all of the patients. And second was hypercalciuria with present in both dense 1 and dense 2 in at least 85% of the cases. Incomplete Fanconi was also common in both, with 70, almost 70%. And nephrocalcinosis was more common in dense 1 than in dense 2. And you can see failure to thrive is more common in dense 2. And other extra-renal manifestation like neurological symptoms, intellectual disability, cataract, hypertonia, behavioral alterations, all these are usually seen only in dense 2. The other differentiating feature is there is increased CPK and lactic dehydrogenase level in dense 2 compared to dense 1, and this is postulated due to type 1 muscle fiber injury. That is invariably seen in all patients of dense 2 and Lewis disease. So going on to dense disease and kidney, we all know that it is a primary tubulopathy. But other than, although it is only a tubulopathy, CKD is more likely seen in dense patients from 30 to 50 years, and CKD usually stage 2 or 3 could develop earlier on from 10 to 30 years of age. And the decline of renal function is different rates for dense 1 patient, even for same family and even same mutation. and some males progress rapidly to end-stage renal disease, while some others can have just CKD stage 2 or stage 3 for a lifetime. So, although it is a primary tubulopathy, there can be glomerular damage also in dense disease. And initially, it was considered as a mere consequence of tubular damage. But later, it was discovered that there is CLC, calcium chloride 5 and OCRL expression in glomerular compartment. And also, Wang et al. Have found some podocyte food process effacement. And this loss of this receptors in the glomerular compartment can lead to loss of function and primary glomerular cell damage. And the nephrotic range proteinuria seen in more than 30% of dense disease patients is because of this glomerular damage rather than mere tubulopathy. And this podocyte food process effacement, it happens because of the interaction between this our CLCL5 and OCRL gene with coffulin, and this is required for this cytoskeleton function, leading to podocyte effacement. And dense disease in female.
Can you be a bit brief? Just don't describe everything. Just say the salient features of female, just the table entries.
Although it's X-linked recessive, females can also sometimes carriers can present with clinical manifestations. Like in a cohort of 95%, there was low molecular weight proteinuria, and this happens because of inactivation of the X chromosome. Going on to detail of the OCRL gene, so it is a multi-domain protein. It has a pH.
Make it brief.
pH domain, 5-phosphatase domain, ASH domain, and Rho gap domain, and it is encoded by a 23 exon containing gene in XQ. And this pathogenic mutation, Lowe's, this is important for the difference between Lowe's and dense 2. So Lowe's syndrome occurs when there is mutations in exon 8 to 5 and 8 to 23, which comprises of this inositol phosphate, ASH, or Rho gap domain. And dense 2 disease occurs because of exon 1 to 7 mutation, which encompasses this pH domain. And the mutations in this OCRL, although it is present in both, some mutations are common. Same mutation can lead either to loss or dense disease, but the difference is mutations that cause the milder dense disease is always a missense mutation, and the mutations that cause dense are closer to the N terminal. So they allow expression of splice variants. So there is some retaining of the biological activity in dense 2 compared to Lewis disease. And the other thing is genetic background greatly influence the clinical expression. Even two individuals with same mutation from same family can have highly variable expression.
Yeah, I think we'll skip the LOE. Let's go to the next slide. Our treatment plan for this patient. We don't have time. We just all right. So this is a clinical criteria, right? And the management. Yeah. Okay. Let's go through clinical criteria.
Okay. So clinical diagnosis, it is either all three of the following criteria, that is low molecular weight proteinuria, hypercalciuria, and at least one of the following, that is nephrocalcinosis, kidney stones, hematuria, hypophosphatemia, renal insufficiency. And the clinical diagnosis is supported by history of X-linked inheritance of renal Fanconi and or X-linked nephrolithiasis. But if we have the genetic mutation with either one of the above will be sufficient to make the diagnosis, and confirmation is by identification of the mutation in CLCN5 or OCRL5. Management of the disease, it is usually mainly supportive, focusing on the prevention of nephrolithiasis. Thiazides can be used to treat hypercalciuria. ACE inhibitors and ARBs have been used in preserving further kidney loss to reduce proteinuria, but its use is unclear. And patients with ESRD will need renal replacement therapy or renal transplant. And patients with bone disease should be treated with vitamin D supplementation, phosphate repletion. And growth failure may be treated with growth hormone therapy, which does not affect adversely the kidney function. And evaluations following initial diagnosis, following the diagnosis, there should be assessment of renal function, assessment for nephrocalcinosis, and those with evidence of renal stones of nephrocalcinosis, urine studies for kidney stone risk factors should be done. And bone health should be evaluated, and those with evidence of bone disease or growth delay, complete bone health assessment, including vitamin D, PTH, X-ray should be considered. And in children with short stature, growth hormone can be given. A patient should be evaluated for any intellectual disability. Eye should be examined for any cataract. Counseling should be given from a genetic counselor. And although there is high muscle enzymes, it is not necessary, but it can be done.
Moving on to the second case for the day. So a 75-year-old patient presented here with history of proximal muscle weakness and mild disorientation since the last 6 months. So the patient was initially admitted to a local hospital with the above complaints, where a provisional diagnosis of CIDP, proximal myopathy, NMJ disorders was made, and she was treated with steroids and mycophenolate mofetil. However, the patient had persistent hypokalemia, which was present even before starting the steroids. So in that hospital, an NCS was done, and it showed axonal sensory polyneuropathy involving both the lower limbs and no features to suggest CIDP. So in that hospital, they did an acetylcholine receptor antibody test, which was negative. Following that, they did an EMG, which was not suggestive of any anterior horn cell disease. So there, in view of the persistent hypokalemia and features such as hirsutism, Schreier, proximal muscle myopathy, and a probable steroid excess state was considered, and her steroid was tapered and stopped. So in that hospital, they did an ANA profile, which was negative. They did a C3, C4, P ANCA, C ANCA was also done, which was also negative. A serum protein electrophoresis was done, which showed no M band. They did an ONDST, which was unsuppressed at 21.55 microgram per deciliter. Following that, they did an LDDST, where the cortisol was again unsuppressed at 39 microgram per deciliter. And they did an ACTH, which was elevated at 77 picogram per ml. So in that hospital, she was not started on any treatment for Cushing's during that admission. Over there, they also did a plain MRI brain, which was normal. Past history, she gives history of diabetes since the last 1 year, systemic hypertension since the last 1 year, hypothyroidism, which was a newly diagnosed query central, query CQ thyroid, and dyslipidemia. She had history of steroid intakes for the proximal muscle myopathy as described before. There was no history of any fractures, no history of TB, no history of recent weight gain, no history of any known addictions. On examination, when we examined, she was conscious, disoriented, GCS of 11/15, E2V4 M5, BP of 130/80, a pulse rate of 110. She had hirsutism present and upper body obesity with thin arms and legs, thin skin, and an old bruise mark on the abdomen. So over here in our hospital, a 75-year-old patient admitted for evaluation of ACTH dependent Cushing syndrome, and on routine evaluation, the patient's chest X-ray showed increased haziness on the right side, as seen over here. So based on the X-ray, it was advised to do a CCT chest. So when the CCT chest was done, it was suggestive of a partial filling defect in the segmental right pulmonary artery, leading to a right upper lobe cavity and a cavity in the right lower lobe superior segment. So over here, this is what they had told was the slight filling defect that was seen in the right pulmonary artery. And over here, the cavities that were present in the right upper lobe and in the superior segment of the right lower lobe, the cavities that were present. So over here, along with this, a possibility of an infectious etiology was also made, and the patient was started on broad spectrum antibiotics. Following this finding, the patient was planned for a CT pulmonary angio and anticoagulation. However, she developed hematochezia, and it was not given at the time. So we also had a reservation about an HD-DST in view of worsening proximal muscle myopathy and worsening clinical condition. So it was not done at the time. So following this, the patient was started on ketoconazole with LFT monitoring along with potassium supplementation. And in view of the hematochezia on day 2 of hospitalization, a sigmoidoscopy and a contrast CT of the abdomen was done, which was suggestive of a colonic diverticulosis, query angiodysplasia, and a rectal ulcer. So as the patient's clinical condition was worsening with an increase in cortisol levels along with worsening of her LFTs, she was started on tab abiraterone acetate 500 mg BD for Cushing syndrome while ketoconazole was tapered. So when she was admitted, her cortisol was 38, and then it started showing a gradual increase along with worsening of her condition. So to rule out a pituitary lesion, even though the MRI outside was normal, we repeated an MRI pituitary here, which was suggestive of features of a microadenoma measuring 3 into 3 mm involving the left half of the pituitary gland. And the pituitary stalk was central, had a thickness of 2 mm, and there were no paracellular or supracellular lesions that were seen. However, even with this, an ectopic source was not completely ruled out. So her initial labs when she came, it showed an elevated SGOT, SGPT at 41 and 45 respectively, a normal serum creat. She had ACTH at time of presentation was 111 picogram per ml. Her T4 was low with a low TSH as well, and the cortisol was 38. A D dimer was also done, which was elevated at 2.26 microgram per ml. So during the hospital, her ketoconazole was tapered and stopped.
Fish, can we stop it?
Yes, sir.
Ma'am, let me summarize this. So we have this a lady with ACTH dependent Cushing with a lot of proximal myopathy and kind of a delirious state and all. And we had features of pulmonary embolism and all these bleeding manifestations. So our thoughts were we had to find a way to bring the cortisol down quickly. And we had observations about hiking up the dose of ketoconazole. So those were our thoughts. So we had to find a way to bring the cortisol down, and that is why we kind of honed in on abiraterone, because we noticed that a lot of these prostate carcinoma patients, a lot of them roaming around without any side effects. Although the liver dysfunction is a known side effect, we saw a lot of patients with this thing. So that led to the idea that probably we can try this and see what happens. And we studied the literature, and Krish will come to that later. So the idea was to bring down the cortisol, and what can we use without sticking our neck out too much. So that was the thing. Okay, Krish.
Have you had any experience with Endomedicine, Praveen?
Yes, ma'am. Endomedicine, I think we have used for 3 patients. That's what I remember. But that is all for pre-op settings, ma'am. Meaning, we put them in ICU, start the infusion, and then they are taken up for adrenalectomy. All our patients had undergone adrenalectomy, bilateral adrenalectomy.
So, since you said that her condition was worsening, had you thought about it? That's all.
Yes, ma'am. The reason was we thought, we didn't want her to go into ICU. We knew that, with the nosocomial infections and all, we tried to keep her out of ICU. She went into ICU, not in the main ICU, just for 2 days. So, once she goes on to ventilator, we are almost sure that we will never get her back. So that was one of the considerations. And again, Endomedicine is probably a short-acting one, ma'am. We had to find a kind of a long-term solution.
Yeah, go ahead, please.
So moving on from that, the ketoconazole was slowly tapered and abiraterone was continued. And to counter the possible mineralocorticoid excess, spironolactone was also started. And with the above treatment, the patient's cortisol reduced and she was started on prednisolone 5 mg 2.5 mg, which was later tapered to 2.5 mg BD. So the patient was started on a block and replacement treatment with abiraterone and prednisolone. And with the above measures, the patient's hypokalemia improved and her LFT also improved. Her potassium from 3.1 slowly kept creeping, and then it was within normal range. Her SGOT, SGPT also, which were elevated initially, had also come down to a normal level. So she was planned for a gallium dotanox scan to look for ectopic ACTH sources on follow-up. So this is just a chart showing her cortisol level on admission. It was rising, and at 59 over here, we had initiated abiraterone acetate. That was on the 20th, and within a period of 7 days, her cortisol drastically fell down all the way from 51 to 6. And once it reached 6 on 28, the patient was started on prednisolone. During the same period, her potassium also over here, along with abiraterone, we were giving spironolactone, and her potassium was well maintained during this period. And from here, the patient was started on a block and replacement treatment where we continued her on abiraterone along with prednisolone. And she was continued until discharge on 5th when her cortisol 8.3. So following this, the patient followed up after a month with good clinical improvement. And in view of age, she was planned for conservative management for the same. On follow-up, after a month, her sodium potassium were within normal. Her cortisol was still suppressed at 3.3. SGOT, SGPT within normal limits, and her T4 and TSH was also within normal limits. So the patient was sent on abiraterone 250 mg 202, that is 1 gram abiraterone per day, prednisolone 2.5 BD, spironolactone 50 mg BD, thyronorm 25 in the morning, and for her hypertension, she was on bisoprolol, and for her diabetes, she was on vildagliptin. So based on this, we had come to a diagnosis of Cushing syndrome, ACTH dependent. Query ectopic Cushing's was still not ruled out. Pituitary microadenoma, diabetes mellitus, and systemic hypertension, probably secondary to the Cushing's. Hypothyroidism, query central query sick euthyroid. Hematochezia, which was secondary to a solitary rectal ulcer. Colonic diverticulosis, and a cavitatory lesion in the right and left upper lobe, query pulmonary embolism, query infective, and dyslipidemia. Moving on to the discussion. So what is abiraterone? Abiraterone acetate is a medication that is used to treat prostate cancer. Specifically, it is used together with a corticosteroid for metastatic castration-resistant prostate cancer. So abiraterone was first described in 1995, and it was approved for medical use in the United States and European Union in 2011 for prostate cancer. So abiraterone acetate is a selective and irreversible inhibitor of 17-alpha hydroxylase and 1720 lyase that blocks adrenal steroidogenesis, including cortisol synthesis. So what it does is, so abiraterone acetate is an active metabolite abiraterone is the active metabolite of abiraterone acetate, and it inhibits cytochrome P450 17A1, which basically manifests as two main enzymes, that is 17-alpha hydroxylase and 720 lyase. It has approximately six-fold more selective inhibition of 17-alpha hydroxylase over 1720 lyase that are expressed in testicular, adrenal, and prostatic tumor tissues. So inhibition of cytochrome P450. Okay, so just this is just to simplify it even more. So what abiraterone does is inhibit 17-alpha hydroxylase and inhibit 1720 lyase. So this in turn causes reduction in cortisol and reduction in testosterone and DHEAs. But this also causes a secondary increase in deoxycorticosterone, which can cause an aldosterone excess. So to counter this, we usually start the patient on spironolactone as well. So these are just a few case reports where this drug has been used for Cushing. So this was taken from the Journal of Gastrointestinal Oncology, where abiraterone acetate was used for ectopic Cushing syndrome caused by an ACTH producing neuroendocrine tumor. So here the patient was diagnosed, over here baseline cortisol and ACTH were both elevated. So patient was diagnosed with a metastatic ACTH producing NET. So she was initially started on ketoconazole 400 mg, which was then titrated to 600 mg thrice daily, and for 38 days she received it. However, the cortisol still remained at an elevated level. So abiraterone acetate was started at a dose of 500 mg twice daily, and effects of serum cortisol reduction were immediate, and serum cortisol levels started to downtrend by day 3 of initiation of the drug, and the cortisol levels completely normalized within 10 days of starting abiraterone acetate, as seen in this study. There was another case report of management of severe Cushing syndrome induced by adrenal cortical carcinoma with abiraterone acetate. So over here, a 50-year-old woman with metastatic ACC was admitted with severe Cushing syndrome that was not controlled with mitotin. Patient was In this study, the patient was ineligible for ketoconazole due to hepatic disease extension, and metropone was not commercially available in Italy. So they decided to administer abiraterone acetate while mitotane was interrupted. Again, she was started on 500 mg, 2 tablets were introduced, and after 5 days of therapy, the patient reported dramatic subjective clinical improvement. Over here, you can see that the levels of cortisol had decreased by 2/3 from baseline. And more importantly, the clinical manifestation of cortisol excess were also significantly improved. So over here, you can see at baseline, they had a urinary cortisol of 1,863 microgram in 24 hours. And within day 9, that is 9 days of starting abiraterone, it had come down to 520. So this observation suggests that abiraterone is promising in palliative care of patients with Cushing syndrome that is recalcitrant to mitotane treatment. So concluding the case, in this case, abiraterone acetate showed significant effectiveness in promptly normalizing cortisol levels and suggesting a potential avenue for managing complex case of Cushing syndrome. This outcome prompts further investigation into abiraterone acetate's therapeutic role, offering a glimpse of hope for patients navigating the challenges associated with hypercortisolism. Thank you.